to 1965. You'll want to listen to this. People born during these years are 5 times more likely to have hepatitis C. But many people living with hepatitis C don't know they're infected. You can live with the disease for decades without having any symptoms or feeling sick. Over time, hepatitis C can cause serious health problems, including liver cancer. A blood test is the only way to know if you have hepatitis C. Here's the good news. Hepatitis C can be cured. So, if you were born from 1945 to 1965, CDC recommends you get tested for hepatitis C because you still have a lot to look forward to.
Folic acid is a vitamin which can protect a developing baby from getting a serious problem that can cause difficulties walking.
Spina bifida, anencephaly, these are major birth defects that are either fatal or have serious long-term consequences for the child.
And in contrast to polio, where you only get motor, you only lose motor function, with spina bifida you lose both motor function and sensory function.
We estimate that about 300,000 babies are affected by neural tube defects around the world. Dave and Godfrey Oakley invited me to come to CDC to work on the Vietnam Veterans Agent Orange risk study for birth defects. And we analyzed that data and published it. It was one of the first population-based studies that was done to show that folic acid in a multivitamin could reduce the risk of neural tube defects.
And it was enough to prompt us to figure out whether this was really an idea worth promoting on a public health scale, or whether it was something that was just a fluke.
June the 24th at 5 p.m. 1991 was probably the most marvelous professional moment of my life, when I got a call from now Sir Nicholas Wall telling me that the randomized controlled trial that he had done to find out if folic acid or a different vitamin would prevent spina bifida, it had turned out to be such a positive study. It prevented 72% of spina bifida and anencephaly, and it was in the gold standard study that we called a randomized controlled trial. And it meant that we could bet the farm that folic acid prevented spina bifida.
So you're doing something that prevents diseases and prevents conditions, with the result of not only saving children's lives, but improving their quality of life.
So the first thing we did was make a recommendation for women who had previously had an affected child with either anencephaly or spina bifida, these 2 very severe birth defects. And that was one of the easiest policy things I ever did at CDC.
This was a special recommendation because it called for what we now call a high dose of folic acid, a pharmacological dose of folic acid.
If you can prevent something like this, especially on the scale of preventing thousands of these birth defects, then this is a real accomplishment.
How much prevention you get depends on how bad off you are.
The China study was really public health at its best.
At the time we did the China study, people didn't know for certain whether folic acid by itself would prevent neural tube defects.
We sent RJ off to China to do a large community intervention. He wound up showing some really fascinating things.
We were asking folks in the field, the health providers that were in the villages, to take pictures of these babies in a way that we could then use the picture to make a diagnosis.
Among the things that he showed was that how much prevention you get depends upon how high the incidence is when you put the folic acid into the population. And in parts of China, it went down almost 90%.
And the China study was the first and only study that showed that folic acid by itself, without other vitamins, prevents neural tube defects.
And from that moment on, I knew that all we needed to do to keep tens of thousands of kids each year out of wheelchairs was to get every woman of reproductive age 400 micrograms of folic acid every day. We have lots of success stories about preventing spina bifida with folic acid fortification programs. And the key is you have to make it so that every manufacturer has to do it. So in the U.S., you know, it was prohibited before February of '96, and then it was required 21 months later. And so beginning in January 1, 1998, all enriched grains in the U.S. had to have folic acid in it.
So once the folic acid was added to cereal grain products, added to the flour that goes into the bread that we eat and other cereal grain products, then you want to count how many cases of neural tube defects there were.
It has resulted in a substantive reduction in the occurrence of neural tube defects among babies who have been born in the United States.
There are roughly 300,000 cases of anencephaly and spina bifida around the world, and we're preventing someplace around about 15% of that. So one place on the order of 20,000, 30,000 a year. And it's wonderful. I mean, thousands of kids don't have spina bifida and anencephaly.
To have something so simple as folic acid in fortified foods that can prevent 50 to 70% of these children from having this condition and actually being born healthy, to me, is a success story beyond belief.
Smallpox is gone. Polio is on the way to being gone. I'd like for spina bifida F to be the next one.
And that to me is an exceptional thing to have happened, and I have had the opportunity to be part of that.
Tough not to be an evangelist for this, you know.
Welcome to Beyond the Data. I'm Dr. Phoebe Thorpe, and here with me today is Dr. Peter Striebel from the WHO in Geneva. Thank you very much for joining us, Peter.
Thanks, Phoebe.
We're here to talk about measles and eliminating measles. Many Americans have never seen measles, but it happens in a lot of other places in the world. Can you tell our audience a little bit about the variability in measles across the world?
Yeah, sure. So I think it's important to recognize that measles manifests itself very differently depending on the underlying nutritional status of the child. Mm-hmm. So in the United States, where there's good nutrition, good access to health care, the complications are relatively rare, and often measles is transient, lasts about a week, fever, rash, sore eyes, cough, and the child gets better. However, of course, occasionally, so about 1 in 1,000 cases can get an inflammation of the brain, and probably 1 to 2,000 may actually die. So while severe complications are rare, they do occur. Mm-hmm. But the general perception among parents and even providers is that it's a relatively mild illness. Contrast that with a developing country setting. Vitamin A deficiency, mm-hmm. protein energy malnutrition, where children are really malnourished. Here the picture's very different. Children get severe pneumonia on top of the measles, and the proportion who die can be as much as 1 in 10. So you're looking at 1 in 1,000, 1 in 5,000 in the US versus 1 in 10. Very different mm-hmm. disease, and so parents in the developing world really are fearful of measles. So a very different perception of risk if you're in an industrialized setting with good nutrition versus, a much tougher socioeconomic setting.
They do say about measles, though, that a case anywhere means a case everywhere. Right. What can you say about that? Because that's an interesting saying. Yeah.
So this is the other thing that's really important. Measles is very infectious, and so in the pre-vaccine era, basically everybody got measles. very rare to get to age 15 or 20 without having had measles. It's that infectious. And so as a result, if you have an outbreak, and for example, we have an outbreak now in Mongolia, we've seen cases have occurred in the US as importations. So, and this is how easily measles spreads. Because it's that infectious. The flip side is that for vaccination, basically all children must be vaccinated, because if 1 in 20 or 1 in 30 people in the population is not vaccinated, measles can get in and can still spread. So the level of immunity in the population, vaccination, has to be extremely high. And it's higher than pretty much any other vaccine-preventable disease. So that infectious capacity, the ability for a person who's, and also early on in measles, you're not symptomatic, you don't feel sick. So for 4 days before you get the rash, you feel fine, and you can travel around, but you can spread. Hence spread on airplanes, in public places. So the measles anywhere is a risk everywhere. Is a reality we face all the time.
That is very interesting, because that makes me wonder about what strategies you have to do, because it almost sounds like you have to vaccinate everyone. And that's a hard goal to reach. Can you tell me about some of the strategies that you know are working, and then maybe some of the areas that you're having difficulty making those strategies work?
Right. So our fundamental strategy is to vaccinate children as soon as they turn 12 months of age. That's in the US, for example, and that's because maternal protection wears off during the first months of life, and by about 9, 12 months, the infants are susceptible. So our primary strategy is on-time vaccination with the first dose at 12 months here in the US, and then a second dose at school entry. And the timing is really important, because you can imagine if children are late or miss their dose, they build up in the population, and there's a risk of outbreaks. And as I mentioned before, you need 1 in 20 susceptible, and you can have an outbreak that continues to spread.
So when you say 1 in 20, you mean if there were, say there were 100 children in the room and only 5 were not vaccinated, that would be enough to continue to spread it?
Correct.
Wow, 5 out of 100 is all you need.
So your program goal practically is all children, because some children cannot get vaccinated because they're immune suppressed, for example. So those few, so programmatically we really have to stress on-time routine vaccination with the first dose and with the second dose. This is really critical. And in the US, this really works well, because you have the school entry check and very high coverage at that stage. In developing countries where programs are weaker, maybe only 1 in 3 or 1 in 2 children are getting vaccinated. So coverage can be quite low in some places. We use what we call a campaign strategy. So periodically, every 2 to 5 years, we'll do what you call a mass vaccination campaign, where you target children, you target all children, particularly those who've missed their routine vaccination. So even, let's say, 4 out of 5 children are getting routine vaccination. That's enough over a 3 to 4 year period to build up susceptibles. And so that's why we do what we call preventive campaigns. And then the sort of last strategy, the fallback strategy, is if you've missed them in routine, if you miss them in the campaigns and you have an outbreak, we do outbreak response vaccination, just to kind of dampen the spread and reduce severe cases and deaths. So that's the basic sort of lineup of strategies.
Okay. And so the other thing that I've heard some today is about rubella. So tell me, why are they doing measles and rubella together?
Right. Well, here we've got a great opportunity, because both diseases are manifest as fever and rash. So it's when you're doing, from a clinical point of view, or when you're doing surveillance, you look for children with fever and rash, and you test them for both. The other big advantage is the vaccine comes in the same vial, in the same syringe. In fact, here in the US, all children are getting measles, mumps, and rubella, the sort of triple jab. So we really have a 2-for-1, or in some cases a 3-for-1 opportunity that if you're going to vaccinate children against measles, you might as well do rubella, and if it's economically possible, mumps as well. Now, in the developing world, because mumps is less severe and also is not really eradicable because you have the protection wears off over time. So internationally, the focus is really on combined measles rubella because both are potentially eradicable, and of course this severe diseases, and the vaccine price is not that much more. Single antigen measles about 20 US cents per dose, and combined measles rubella is about 50 US cents a dose.
Okay.
So yes, there's an incremental cost, but relatively small, when most of the cost actually is related to the delivery,
getting the campaigns and
or
logistics
just getting
around
the logistics, getting the staffing, getting the cold chain in place. So yeah, our real focus now is a combined measles rubella effort in the industrializing the developing country world.
I heard you talk about the strategies that you use to work and some about the funding. Are there barriers that you would like to talk about?
Sure. So I think the situation with measles specifically has been, it's a little bit been in the shadow of polio eradication and international interest in introduction of new vaccines, such as vaccines against diarrhea and pneumonia. So the real investment over the last 5 or 10 years has been in those areas, and measles and rubella have been a bit overshadowed by those priorities. However, things are getting better, and Gavi, the Global Alliance for Vaccines and Immunization, has recently put forward nearly $700 million over the next 5 years to support measles and rubella vaccination, and so this is very welcome.
Okay.
The reality is, though, there's still a shortfall. We estimate roughly $1.4 billion US needed for the supplementary control activities between now and 2020. So Gavi's come up with nearly half of that. The Measles Rubella Initiative has about 300 million. So there's a shortfall of about $370 million still for critical mass vaccination campaigns against measles and rubella between now and 2020.
Okay, so I think what I hear you saying is and I don't want to put words in your mouth, but we kind of know what works, but it's gathering the resources and putting them together and then moving forward on it.
Right.
Yeah.
No, I think here, this is a situation, the vaccines we have are fantastic. They really work, they're safe. Our real battle or our challenge is getting them used. And so this is where both the resources are important, and I think also just the commitment within the countries to really take this up, particularly if they're war-torn, if they have other natural disasters. These sorts of settings are where you really get children who are unvaccinated, and measles is really a big risk.
One of the points that came out in the session today was that the WHO has set the goal that 5 out of the 6 regions would have the measles eliminated. That's pretty close to eradication. Can you tell me, and it was by 2020, can you share a little bit your thoughts about that, how reachable that is?
Right. So firstly, there's what's called the Global Vaccine Action Plan, which sort of defines the global effort across all vaccines from 2011 to 2020. And in there, 5 of the 6 WHO regions are targeted to have eliminated measles and rubella. But in fact, all member states in the 6 WHO regions have individually established a target date for measles elimination on or before 2020. So from a biological point of view, if all the countries succeed at the same time, we have global eradication. So that's the technical biological stand, which, as the experience in the Americas shows us, this can be achieved. However, what's missing is real consensus and political commitment and financial commitment up front to go for global eradication now. So, and I think the reason is, obviously, we're still in the last stages of the battle with polio eradication. So I think people are very mindful of finishing that battle first. I think that's a critical point. And also then mustering enough financing up front, because for eradication of measles, it would be very important to go fast and hard, because what we learned from polio is if you drag this, if this goes on for a long time, it's very costly. It takes up a lot of time and resources. So just to make the point that we do not yet have a global eradication goal, but we do have individual member countries and the regions targeting elimination.
Thank you very much for joining us. I appreciate it.
Thanks for having me.
And thank you for joining us, and we'll see you next time on Beyond the Data.
Over 2,000 CDC laboratory scientists work with some of the deadliest health threats in the world to protect Americans.
This group is unique in that we are the primary source at CDC that tests and evaluates tissues with unexplained deaths. We can test for over 200 pathogens, including viruses, bacteria, parasites, fungi.
Many times you have a sick patient and the doctor can only tell them, we don't know what's causing this infection. They send it to us and we can identify it. With that identification, it gives them the knowledge to be able to treat that disease.
I think some people find it surprising that lab workers go out into the field. For my branch, it's very important. That way we find the animals and try to better understand where the virus is coming from.
In this lab, we're looking at chemicals that are present in the environment and are chemicals that may be affecting human health. In particular, in this lab, we're looking at pesticides.
Let's say that there's a hospital or something that has a excess number of a certain infection of some kind, then we can go in and we can look at the water, we can look at all the environmental sources like the air, and make sure that we're finding where those things are coming from so that we can stop them.
I do all the testing, mostly for the state health departments, but we do also test samples from all over the world.
A select agent is, for example, a bacteria or a virus that the government has felt that if it's in the hands of the wrong person, that it can be very dangerous to public health. When we go on inspection, we look in every aspect of a program, safety, security, training, records, to ensure that these programs are also doing their job at the highest level possible.
One of the things that's most exciting right now is the power of technologies that we're calling advanced molecular detection, which is the ability to determine the entire genetic sequence of a pathogen in a matter of days, which just a few years ago would have taken weeks or months.
Because we can do these things faster and because we can do them reliably and better, we can isolate those patients, we can prevent those unusual kinds of resistant bacteria from spreading from patient to patient.
During the Ebola response, CDC rapidly set up a lab in the middle of Sierra Leone to test patient samples for Ebola. The lab out in the field is providing a service that is critical to the investigation, identifying patients as well as ruling out patients so that they could then go on with their life.
I think knowledge and a better understanding of dangerous pathogens is our greatest tool at minimizing the risk and public health impact of these pathogens. Whether that's improving diagnostics or finding more effective treatments or developing vaccines, it all starts in the lab.
My kids, they know what I do. They're proud, and I'm proud also to be working here. It's a very great place to work.
I think the most important thing about public health is that the work that we do here, myself and my coworkers, is work that saves people's lives, and those are real people. Those are people's moms and dads, and that's important to me.
We live in a world of technology, and there is a huge amount of technology that is focused on our health. The evolution of technology and wellness programs has really escalated over the last few years. Employers are motivated to implement wellness programs for a variety of reasons. Certainly managing healthcare costs is still a big concern, but increasingly, and especially as the younger generations have come into the workforce, there's been much more of a recognition that you really have to look after the well-being of your employees. A health portal is a comprehensive tool that offers a variety of different types of resources to your individual program participants. One of the real benefits of a portal is that it provides a lot of administrative tools. So it can provide event registration, incentive program management and tracking, and a variety of different types of tools that focus on communication. So there's good news and bad news about health apps. The good news is there's a whole lot of them. The bad news is there's a whole lot of them. You don't find what you want on the marketplace, and you might decide to develop a custom app for your own workforce, which is a great option because then it's all about your team and what your team needs. Wearable devices are very popular. Many health portals support a lot of different types of wearable devices. One of the real advantages of social media is that a lot of people use it. It can be used for both content, to deliver content about your program, communications, and also for the purpose of bringing people together. You know, the whole point of social media is to be able to create connections with people. And as human beings, we're wired to be connected. The place we often see resistance from employees in the use of technology in a wellness program is that you're asking them for personal data in some cases. And in some cases, you're actually asking them for personal health information. And as we know, personal health information is protected. Well, it is a tough balance to be able to make sure that you can accomplish what you want to in your wellness program, and at the same time, honor and respect the wishes of your workforce. So sometimes the way that is done is by using a third party as the intermediary for collecting of that data. And that way the employer doesn't actually have access to the direct access to the data, and that employees can feel that there's a bit of a firewall there that would protect their individual data. When we think about value and investment with regard to wellness programs, what we're really looking at is how the program is providing value to the organization beyond just the measurement of changes in medical costs. If you are trying to attract high-performing workforce, having a wellness program and using that to attract employees to come and work for you, that has a very high value to the organization. The program is more than just the technology itself. It's the goals, the objectives, it's understanding what your interests are of your workforce, what their needs are, and what policies you implement in the workplace that support and encourage healthy lifestyles and encourage well-being associated with all of that. So think of technology as a tool, not as the whole program.